My name is Adele Perry. I am a settler, I'm a historian, I'm a mom. I teach here at the University of Manitoba in the departments of History and Women's and Gender Studies. And I also have the real privilege of being the director at the Center for Human Rights Research. And this is the first of our 2026 Critical Conversation series. And this is an annual event of public seminars or discussions that the Center for Human Rights Research has held since the center formed in 2012. And the Center for Human Rights Research is sort of based here in the lands and the waters of the Anishinaabe, the Innu, the Anas Innu, and Métis peoples. And we are a treaty partner to the first of the numbered treaties and also to the Manitoba Act. This year, the Critical Conversations series is a series of 3 events, each of which engage in an aspect of interdisciplinary and intersectional feminist research methods. And this year, this series is being held in conjunction with a class, and this is often the case. And this year, I am lucky enough to be teaching Women's and Gender Studies 3000, which is interdisciplinary research methods in women's and gender studies. So this is partially the work of our class, and it's great to have everybody from that group here. But it's also an opportunity for us to kind of broaden the circle a little bit and to bring in perspectives on research that kind of enrich the work of that class. And when we talked about this event, when we kind of came up with the plan back in the day, I don't think we had in mind, and maybe anybody can correct me if I'm wrong, that today is the day that actually marks exactly 30 years since Supreme Court of Canada versus Morgentaler decision came down, which took abortion out of the criminal code in Canada. It's the actual exact anniversary. Sometimes you cannot plan things like this. It just happened. But here we are on a day which is a significant kind of milestone in histories of reproductive justice in Canada. This was a decision that shifted the landscapes around bodily and reproductive autonomy across Canada. But it certainly didn't change everything. And I think one of the really crucial things that the report that Emma Cowman and Lindsay Larios and their colleagues have put together, and that Emma and Lindsay will be talking about, makes clear is that reproductive justice remains elusive for many people in the particular context of Manitoba and across Canada. So today provides us with an opportunity to both mark this milestone and consider the very real questions of access that people seeking this particular form of healthcare, that is abortion, continue to face. To the south of us, we are seeing in real and horrifying time the ongoing assertion of unchecked state power against migrants, or people perceived to be migrants, or also people perceived to be supporting those people. And we know that this is connected to ongoing histories of Indigenous dispossession, of slavery's afterlife, and of gender-based violence. And it is also connected to ongoing challenges towards reproductive autonomy and justice. And it's an important moment to hold all of these goals and all of these projects in our minds and remind ourselves in the way that they are in conversation and how they are connected to human rights and when they fail us. So we're particularly lucky to be doing this work here in these spaces and to be able to have Emma Cowman and Lindsay Larios join us today. I'm going to introduce them really briefly, and then they're going to speak for about an hour. You'll notice that there are cards on your tables, and if you have a question, you can jot a question down there. We are filming this event, and that is something that is good to keep in mind. There's also coffee, water, and snacks, and you can get up and get them at any time. But the speakers will speak for about 50 minutes / an hour, and then we will take up some of the questions that people have written down on the cards. So Emma Cowman is in the second year of a Master's of Social Work program. Emma graduated from the University of Regina with a BA in Psychology Honors and Women's and Gender Studies, and Emma's research interest includes reproductive justice, to us LGBTQIA plus rights and gender-based violence. And Emma is currently working on a thesis which explores queer experiences of accessing abortion care in Manitoba, and is also working on this project, the Abortion in Manitoba project, with Dr. Lindsay Larios, and a number of other projects, including the Just Waters project, which is something that we also work on here at the Center for Human Rights Research. Dr. Lindsay Larios is an assistant professor in social work and an interdisciplinary critical policy researcher. Dr. Larios studies citizenship and immigration in the Canadian context, and how it intersects with family and reproductive justice and politics. And Lindsay's most recent work focuses on the politics of pregnancy and childbirth and precarious migration as an issue of reproductive justice. Lindsay and Emma have both worked with us at the Center for Human Rights Research in a whole number of capacities, and it's a real honor to have them here and to be beginning this series and to be doing this really, really important work and sharing it with us. So I'll pass things over to Emma and Lindsay.
Thank you, Adele. Good afternoon, everyone. Thanks for coming out today to share with us kind of some of this work, and thank you for the invitation to present on this project. And it's especially exciting, as Adele mentioned, to be here on the anniversary of the decriminalization of abortion in Canada, and so we're really excited that that we get to be here. So thank you so much. So as Adele said, I'm Lindsay Larios. I'm in the Faculty of Social Work, and with me today is Emma Cowman. Just also want to acknowledge the research assistants of Melanie and Olivia, who were also a big part of this project but could not be with us here today. This project was funded by Research Manitoba and was done in collaboration with the Women's Health Clinic, the Northern Reproductive Justice Network, as well as the Center for Human Rights Research. Members of WHC and the Northern Reproductive Justice Network were involved in the original articulation of this research, consulted with for the creation of data collection materials, like the survey and the interview guides. They helped to facilitate recruitment and spread the word about the project, and have been available for consultation and feedback throughout the process. So we hope that the information we've collected is able to aptly capture the experiences of folks who have accessed abortion care in Manitoba and can be helpful in some way to this work moving forward. So this research was primarily conducted on Treaty 1 territory, with participants and collaborators also from Treaty 2 and Treaty 5 territories. We engage in this work because we want to contribute to advancing reproductive justice in Manitoba for everyone, and this means advancing reproductive autonomy and dignity for all and dismantling barriers to that end.
Okay, so we're just going to begin with some background on abortion access in Canada. So as we mentioned, today is the anniversary of the R.V. Morgentaler Supreme Court case, where abortion was decriminalized. Following this case, this removed abortion from the criminal code and then regulated it under the Canada Health Act, just like any other medical procedure. Then decades later, in 2015, we see medication abortion was approved for use in Canada, and this further expanded options, abortion access options for people in the earlier stages of pregnancies through accessing medication, which can also be taken at home. However, even with these advancements, abortion access in Canada does remain uneven due to a wide range of factors, including geography, as most abortion sites are located in urban centers, causing those living rurally, remotely, having to travel to access care. There's also infrastructure concerns, as some provinces and territories do lack the necessary healthcare infrastructure to provide access to consistent abortion services. We also see stigma and interpersonal barriers prevalent across Canada, as abortion continues to be a stigmatized procedure, and people who want to access abortion may encounter judgment from healthcare providers. They may face misinformation or even feel pressure from family and friends. And then lastly, politics as abortion remains a contentious issue within politics. We see how provincial governments control how health services are delivered and funded differently across the provinces and territories, and we also see periodic attempts to reopen the abortion debate at the federal level. And then specifically looking at the abortion landscape in Manitoba, we see some of the same challenges as those across Canada, in addition to some unique challenges to this province. So geographic inaccessibility is one of the most major barriers to abortion care in Manitoba. Our population is nearly 40% rural and remote. However, procedural abortion care is only offered in Winnipeg and Brandon, as we can see on the screen here. And while medication abortion helps combat some of that geographic inaccessibility, its implementation in rural and northern Manitoba remains uneven, leaving those who are living in these areas often needing to travel in order to access care. And then traveling in itself becomes difficult in Manitoba following the Greyhound bus service discontinuation in 2018, and this removed a critical transportation option for those needing to travel from rural areas to urban centers to access healthcare. And then Manitoba's abortion landscape has been shaped by a variety of political challenges. There's a long history of violence against abortion providers in the province, including a shooting, harassment, and threats. And this has contributed to the ongoing provider shortages and also caution taken amongst providers. And then anti-abortion organizing is ongoing and prominent across southern Manitoba, including on our university campus here, through protests, through unregulated pregnancy centers, which are centers that seek to dissuade folks from accessing abortion care, among other anti-abortion strategies. And despite these challenges, we do see there have been progressive political developments made to improve abortion access in Manitoba. We've seen the coverage of medication abortion in 2019 under Manitoba Health. We've seen more recently Manitoba has implemented a protest buffer zone around abortion sites. And we've also signed on to National Pharmacare. Before that, had our own provincial birth control program. So while we can see that Manitoba is taking important strides, there are significant gaps that remain across the province in regards to abortion access.
Yeah, so despite this kind of unique landscape, there's very little research on the state of abortion care in Manitoba. And so as such, this study was largely exploratory, just trying to document the state of access and how people were living it day to day. The goals of this project were co-developed with the Women's Health Clinic, which is the largest abortion provider in the province. And these are to understand and document the state of abortion access for people living in all areas of Manitoba, including the policies, care settings, and actors involved, to uncover key gaps and challenges, both formal and informal, to abortion care for people in Manitoba and consider their wider implications, and to have some real tangible resources coming out of this. So to create resources for both public and community service providers to communicate the findings and support practical policy recommendations. So in order to analyze how people in Manitoba are experiencing abortion access, we used the reproductive justice as our conceptual framework. Emerging from the activism and scholarship of Black and otherwise marginalized women and people in the US, reproductive justice is grounded in the Black feminist tradition and normative calls for the right to have children or not, and to parent children in safe and healthy environments, grounded in bodily autonomy. Aligning with the practice goals of our community partners, we adopted an explicitly feminist and action-oriented theoretical framework to ground and orient this work towards feminist praxis. Therefore, we define reproductive justice as the conditions of liberation that will exist when all people have the power and resources necessary to make their own decisions about their bodies, health, gender, sexuality, relationships, families, and communities, to create and choose their families, and to reproduce their communities as a whole, all with dignity, self-determination, and genuine support. As we were engaging in this work and analyzing this data, we aimed to trace these elements of reproductive justice, rights, access, dignity, self-determination, and support, paying attention both to facilitators and barriers.
And then we also wanted to map out the timeline of this project for this presentation, acknowledging that doing feminist community-based research can be a slow and a long process. So our community partner involvement in our community-based research can look many different ways, largely depending on the capacity of partners, but this is how it looked for our projects. So the beginnings of this project were back in October of 2023, just over 2 years ago, with community consultations with the Women's Health Clinic and the Northern Reproductive Justice Network. And during these consultations, our community partners were invited to provide input on the research questions, data collection instruments, and to identify the types of data that would be most useful for their work. And based on these discussions, we pivoted to include a broad survey as well as doing our personal narrative interviews. And then drawing on these consultations, we developed the survey and the interview questions, and then we received feedback from our community partners, making revisions with their feedback before the ethics process. And our ethics process took a few months, but as soon as we were approved, we had the survey ready to be launched online. And a few months later, we began conducting the interviews. Then our data analysis began in September 2024. Took just over half a year to complete, took until May of 2025. And as soon as we finished our analysis, we jumped into conference season, presenting some of our findings at 2 different conferences. And then as soon as conferences were wrapped up, we began the large task of creating the community report that we have here today, which brought together all of our findings. And in this time, we also had consultations with the Women's Health Clinic, where we were able to ask some clarifying questions on abortion programming and also do some site visits to their sites. We also presented at their all-staff meeting in October in this time of the project findings. And once our report was written, we shared it with community partners for feedback back just before Christmas. And then we made the final revisions and launched the report to the public just last week. And from here on out, the work doesn't stop here, and we have ongoing plans for knowledge mobilization to continue sharing findings from this work.
So as we kind of have mentioned already, the methods for this project were both a broad survey and also in-person or virtual one-on-one narrative interviews. So with respect to the survey, in order to document and better understand broadly what access to abortion care looked like in Manitoba, we conducted this broad survey. We used Qualtrics, where recruitment was supported through our community partners and various other organizations who shared posters and postcards and social media posts and that kind of thing. So the survey was open from April to September 2024, and then we analyzed the quantitative data for frequencies and quantitative analysis with support from the Center for Social Science Research and Policy. Our survey elicited 107 responses that fit the criteria. Survey participants ranged from 18 to 50, and of those responses, 43 identified as BIPOC, 12 identified as gender diverse, 41 as low income, 31 as parents, and we can see there's 67 from Winnipeg and 40 from outside. Survey participants could opt to get information about participating in a narrative interview as a follow-up to kind of share their story in more detail. 23 narrative interviews were conducted virtually using Zoom with folks from across Manitoba. So our team used the audio from these interviews to transcribe verbatim, using some software assistance, and then one of our team members would analyze an interview using narrative analysis on NVivo, and we would have weekly meetings where we would collaboratively talk about the data and do some collaborative analysis as a team. So just to give a sense of some demographics, interview participants' ages ranged from 21 to 50. Of these participants, 9 identified as BIPOC, 4 as gender diverse, 8 as low income, 6 parents, 15 within Winnipeg, and 8 outside of Winnipeg. So As we kind of talk about our findings and get into that, there will be pie charts throughout our presentation which reflect the survey responses, which also include those interview participants as well. So just to give a sense of what the data looks like, in our survey, about 95% did end up accessing abortion in Manitoba. About 4 did not access abortion in the end due to reasons such as miscarriage, and 1 person had a self-harm induced abortion. And 1 person received their care in Ontario due to time restraints. So nearly half of participants reported accessing care from Women's Health Clinic, a quarter from HSC, so Health Sciences Center downtown, and about 9 in Brandon. In both the survey and interviews, the type of abortion access was nearly 50-50. So we have both medication abortion and procedural abortion represented here. So we'll go into our findings. We've organized our findings into the 3 stages of accessing abortion care, including finding care, which includes parts of the process from seeking information on abortion up until they attend their appointment. Undergoing care, which includes anything that happens while the participant is at the clinic or hospital or doctor's office for their care, and includes the process of pregnancy evacuation at home in the case of a medication abortion. Post-abortion care and recovery includes anything that happens after, including healing physically, mentally, emotionally, spiritually, and the broader impacts. And lastly, we have a section that really reflects on reproductive justice in Manitoba. So where participants share and reflect broadly on the state of reproductive justice for themselves, their bodies, their families, as well as Manitoba and across the globe.
So we'll start out with our first section, which is finding care. And we've divided this into further 3 subsections, including finding information, making the appointment, and then traveling to the appointment. So using our survey data, we found that just over 50% of respondents found information on how to access abortion online, with others reporting that they sought this information from healthcare providers or through personal networks such as friends and family members. And 56% of survey respondents reported that finding information on how to access abortion in Manitoba was easy. However, just over 1/3, 38%, reported experiencing varying levels of difficulties when searching for information about abortion. And while the difficulties finding information were attributed to a range of factors, including misinformation, stigma, and a lack of publicly available information, many of our participants also talked about and attributed some of their difficulties to receiving inadequate sexual education. So our participants discussed how sexual education from schools is a fundamental source of information when it comes to knowing about their sexual and reproductive health. However, as abortion is commonly excluded from sexual health curriculum and classes, participants felt that this was the first significant roadblock that they encountered when finding information on where and how to access abortion care in Manitoba. Participants also expressed a reliance on their own personal resources when trying to find information on accessing care in the province, and this included doing their own research online or turning to their personal networks for information and support. So as just over half of our participants turned to the internet to find information, many shared with us that there was just simply a lack of information online about how to and where to access care. And when searching for information online, Julia noted that the Women's Health Clinic was, quote, kind of the only thing I really saw. Other participants were concerned with the accuracy of information that they were finding online, sharing that they experienced difficulties finding credible and trustworthy information. Other participants noted how binary the language was online when searching for abortion care, from information about accessing care to the name of the abortion provider sites in the province. The use of highly gendered language posed a barrier for some of our gender diverse participants. And then those who sought information from their friends or their family members had different experiences finding information. Only 11% of participants sought information from their friends and family members, but those who did reported experiencing significant benefits, such as having someone to help them navigate the process and also support them throughout. Riley on the screen here shared how they turned to their aunt for information on accessing care, saying, Honestly, if my aunt hadn't been there, I probably would not have known where to go, and I would not have been able to coordinate those appointments by myself. At the time, I was throwing up violently and starting to feel super sick, and I had no energy to do anything. But I would say if I hadn't had a close family member who was able to take the lead and sort of get me set up initially, I don't know if I would have been able to access it. And then almost 1/3 of our participants reported finding information on how to access an abortion from their doctor or a different healthcare provider. However, many did share that when seeking information from a healthcare provider, they were met with varied responses, including non-supportive care and even refusals to provide information. Stella on the top there, who's from Brandon, but ended up traveling to Winnipeg to access care from the Women's Health Clinic, shared her experience with a doctor in Brandon, saying, quote, "He wouldn't give me information on abortion sites, like not at all. It was pretty scary." Victoria on the bottom there similarly was met with a non-supportive healthcare provider in Winnipeg. She shared, quote, "She pretty much kicked me out of her room and got up and said, 'You have to call this number, I can't help you,' and walked away. I was disappointed that they couldn't provide me with a better understanding." And then when it comes to intake processes, our participants reported experiencing booking their appointments in a variety of ways, including over the phone, in person, online, or through referrals and waitlists. And when booking their appointment over the phone, many of our participants reported having to leave a message on the phone line and then wait for a returning call from the provider in order to complete an intake. And not knowing how long they would have to wait for a call back added to the stress that they were already experiencing. Ivy shared that this was a part of her story, saying, quote, "As soon as I took that second test and it was positive, I need to get this done as soon as possible. And you have to call and leave a message, and then you have to think about how long it's going to take for them to call you back." Then it comes to wait times to access abortion, and these were felt across many of our participant stories, causing feelings of stress and frustration due to logistical reasons, but also in additions of bodily autonomy and control over their body. On the screen, we have a pie chart of how long our survey respondents reported having to wait in between booking their appointment and then actually receiving care. And many participants spoke to how wait times meant having to prolong being pregnant when they didn't want to be anymore. In addition, many participants shared how long wait times prolonged their experience of various pregnancy symptoms, including morning sickness, mental health effects, and even feelings of gender dysphoria. And then we had many participants who acknowledged that the long wait time they experienced is likely due to the limited capacities of abortion providers and sites within Manitoba. Some participants also encountered different infrastructure issues that even prolong their wait times, such as an Ivy story where a water main break at the Women's Health Clinic caused her appointment to be delayed by a few additional weeks. And then we have Quinn on the screen, who was in the beginning of their transition when they discovered that they were pregnant. They shared about the difficulty of being pregnant during their transition, especially as pregnancy is typically considered as a feminine experience, and how lengthy wait times only added to the stress they were experiencing. Quinn shares, "The wait was definitely tough, and then not hearing back was tough. And that frustration of, okay, I really want this service, but I guess the resources are too low to get an appointment. So that was very difficult. And you have all these hormones happening. I had extremely bad morning sickness where I was literally vomiting multiple times a day. I couldn't even really keep water down. So that was really hard for that period of time to wait." And Quinn was not our only gender diverse participant who faced a lengthy wait time, but we found that 44% of gender diverse participants reported waiting 4 or more weeks between booking their appointment and actually receiving abortion care. And then many participants also spoke about their preference of accessing their abortion from a community-based clinic, such as the Women's Health Clinic here in Winnipeg. Naomi on the top there describes that she knows she would have been able to access more pro-choice and compassionate care from the Women's Health Clinic, but due to wait time, she had to pivot and access care from her family doctor, who did not meet her desires and needs in a pro-choice and a trauma-informed way. Then on the bottom, we have Madeline, who similarly wanted to access care and was actually able to do so from the Women's Health Clinic. And she shared that the clinic's morals and the advocacy that they do would make her feel more safe and comfortable throughout the process. Then we have traveling to the appointment. And geographic inaccessibility was a significant barrier to care that was noted by nearly all of our interview participants and experienced and lived by about a third of our survey participants. There was a wide range of travel times reported by those who had to travel outside of their home community in order to access care. And while many did report less than 3 hours of travel, we had 5 participants who traveled anywhere between 3 to 6 hours. And we had 5 participants reporting traveling over 8 hours to access care. And while nearly all of our interview participants were located in an urban center in Winnipeg or Brandon and could access care in their home community, many of them, just like Cheyenne's quote on the screen, discussed the multitude of challenges of folks who are from northern or rural communities due to barriers of travel, stigma, and judgment. And then traveling outside of one's home community comes with its own set of costs, with our participants reporting feeling financial, social, and logistical costs to access care. 24 of our participants reported having to miss work without pay to travel to access care. Others reporting missing school or needing childcare. And then many had to spend 1 or more nights away from home in order to access their abortion. And then most of those who traveled to access an abortion reported having to pay out of pocket for their travel and accommodations expenses. And then a few reported being able to get a friend or a family member to help with financially. And others reported that they got coverage from the Northern Transportation Program or the First Nations and Inuit Non-Insured Health Benefit Program. And then lastly on the screen here, we have a quote from an open-ended survey response from one of our northern participants who shared the many social, logistical, and financial costs they experience when accessing care, in addition to stigma and secrecy. And they wrote, had to travel 8+ hours from Flin Flon, Manitoba, had to stay at a family member's house but did not feel comfortable sharing why we were there, had to leave my 9-month-old nursing baby, born at 29 weeks, and had to feed often to maintain weight. We also had to spend a night in a hotel on the way back.
So we'll move on to undergoing care. Here there were 4 main things that people highlighted in their experience. So pre-abortion consultations, interactions with staff and providers, the general infrastructure, safety and belonging that infrastructure facilitated or not, and pain and medical complications. So across abortion provider sites, 78% of participants reported that they felt listened to and respected when engaging in contraceptive counseling. 6% reported not feeling well listened to or respected during these interactions. Of participants who received some form of mental health support at their abortion care appointment, the overall data shows that about 68% found this support to be helpful, while roughly 30% did not find it helpful. However, when we look specifically at BIPOC participants' perspectives of the helpfulness of mental health supports they received, less reported that they found it to be helpful. About 53% of BIPOC participants who received mental health support found this to be helpful, and about 48% did not. Lastly, 71% of participants reported they were overall satisfied with the treatment they received from staff and providers, while about 29% reported they were not satisfied. So many but not all participants reported that the abortion providers they accessed care from offered some form of pre-abortion consultation. In the survey, 49% of all participants reported receiving contraceptive counseling. 51% reported receiving some type of mental health support. Some found these consultations to be helpful, such as Cheyenne, who shares here. Before the procedure, they went through a whole big questionnaire list and they just talked to you. They really wanted to make sure that you were totally okay with your decision and everything. And when they gave me a package of information if I needed to speak to anyone afterwards too, which I thought was really good. They were really nice at the hospital. Their staff were lovely. These ladies were awesome. Survey participants also answered a question about about what might be helpful support pre-abortion, and many reported that an abortion doula or support person would be helpful. 22 mentioned sacred medicines, and 17 reported that access to an elder would be helpful during these pre-abortion consultations. Others, such as Amber here, reported feelings of being judged from staff during these consultations, specifically during the birth control counseling when she did not want to be on birth control. She says here, she kept telling them, I didn't want to hear that. I didn't want to hear about that, but they kept pushing it. All the information, giving me books and stuff, even though I told them I didn't want it. Of those who did not find consultations helpful, they shared wishing that they could have opted out of contraceptive counseling or mental health support, knowing that they didn't need or want this kind of support when they were accessing care. Interactions with staff and providers play a pretty significant role in shaping the experience. So during the pre-abortion consultations and throughout the remainder of the appointment, these were consistently brought up as factors that either provided or felt made patients feel supported or not. When participants such as Madeline had supportive staff, her experience was felt positive and felt more comfortable. As Madeline shares here, what made it comfortable was the staff I was lucky enough to have, especially in my second experience where I spent more time at the clinic accessing the surgical form of care. However, when participants were met with unsupported staff, such as Naomi's family doctor, these interactions made the abortion experience and process all the more difficult. Naomi explains how the interactions with her family doctor was the hardest part of the whole thing, saying that the doctor basically yelled at me for about 45 minutes, telling me that the worst part of getting an abortion isn't the abortion, it's lying for the rest of your life. And you might change your mind, and she was pointing and scolding. There was no comfort, or there was zero comfort, zero. These moments highlight that abortion care is not only about being able to access the procedure, but also about the treatment by those delivering it. Levels of genuine support and autonomy varied considerably across experiences. Participants talked about their embodied experience of getting an abortion, in particular the levels of pain and types of pain that they experienced. We see here about 36% of those who had a procedural abortion reported the level of pain was worse than expected, while 65% of those who accessed a medication abortion reported they experienced significant pain. And certainly the levels of pain and the pain being greater than expected was something that came through frequently in our interviews, especially with people who had medication abortion who were kind of at home managing it alone. The experience of pain during some medication and procedural abortions was commonly reported among participants. For some, the pain was exacerbated by inadequate or inconsistent pain management, unclear expectations, or complications during the procedure. Madeline was one of many participants who shared a traumatic experience with her medication abortion, saying, "In the moment, the experience was way, way different than what was presented to me. It was a very traumatic experience being alone at home. Maybe my own body just reacted more violently to it. But they had presented a little bit of an image of what it could look like, and it was definitely not that, or feel like that." While the experience of significant pain with a medication abortion was more common among our participants, some of those who accessed procedural abortion care also reported feeling pain. Rihanna shared how she didn't get adequate pain management during her procedural abortion. They start, and I remember it was fine at first. Obviously, it was a bit uncomfortable. I didn't necessarily feel pain up until that moment. I don't know what happened. I guess maybe they didn't give me enough pain meds or something. But it wore off, and I remember it wore off pretty quickly. I remember just feeling this awful pain, like I think it was the worst pain ever in my life. Based on our survey data, we also want to note that racialized and Indigenous participants were more likely to report experiencing significant pain during procedural abortion. 58% of BIPOC participants reported significant pain compared to 45% of non-racialized participants. 50% of racialized and 73% of Indigenous participants somewhat to strongly agreed that they experienced significant pain during their procedural abortion compared to 45% of the entire data set. So although we didn't ask specifically about waiting in recovery rooms in clinics and hospitals, it still emerged as a significant factor that shaped participant experiences of abortion care in Manitoba. While some participants reported feeling solidarity, seeing others in the same situation as themselves, others reported feeling uncomfortable and wishing there was more privacy due to feelings of stigma and shame surrounding that kind of care. Riley shared feeling a bit of both, saying, I was sitting in a room afterwards and in the recovery room with a couple other women who had abortions too, but everyone is so embarrassed and ashamed and hiding their face and stuff, which is sad because there's almost a level of solidarity, because it's like, hey, we just all went through this experience at the same time, and like I feel weird and we can't talk to each other about it. I remember me and one other woman made eye contact and she looked at the wall the rest of the time, and I was like, I'm sorry, I didn't mean to look at you. So these statements speak to the varying needs of people during this time, but also the desire for some kind of community and solidarity, as well as the stigma and shame that still persists around this type of care. So we'll move into unpacking this a bit more as we talk about post-abortion care and recovery.
So moving into this next section, we've divided it into 4 parts, which include emotional, mental, and spiritual support post-abortion, impact on personal relationships, mistrust in the healthcare system, and then a desire for community and connection. So many of our participants expressed how they felt that there was a severe lack of emotional, mental, and spiritual support post-abortion. Taylor shared that they, quote, had a lot of support for the initial procedures. I found there wasn't really much support for after, for dealing with those kinds of emotions and things that I didn't realize would still affect me. I didn't feel like there's no follow-up. Well, they call a week later to make sure that there's nothing left and that you're physically okay, but mental health-wise, there's nothing. And previous research has demonstrated that the effects abortion may have on one's emotional and mental well-being are not caused by the actual abortion procedure itself, but rather by the circumstances that surround the abortion, including stigma, shame, or judgment. And our participants suggested that the effects they felt post-abortion could have been supported or mitigated through greater follow-up care. 72 of our survey participants reported that an abortion doula or a support person would be helpful for them post-abortion, while 27 shared that sacred medicines would be helpful post-abortion, 19 an elder, and then 9 suggested other, which included suggestions about mental health support, more information, and even a grief support group that's specific to those who've accessed abortion care. And this desire for more support post-abortion can also be linked to complex dynamics, emotions, and even relationships that people continue to have to navigate after care. For example, participants experience impacts on their personal relationships, particularly on intimate relationships post-abortion, expressing not wanting to have sex with their partner, feelings of resentment towards their partner, and even relationship dissolution. And Amber shared here that the strain that accessing abortion had on her relationship, wishing that she had more support to navigate and process this time in her life. She shared, we got into a lot of fights and it was hard on our relationship because I felt that he was more devastated when he found out. And I wish I would have had a little time to feel what I was going through on my own without having influence from people around me and with the way I was feeling. And we had multiple participants who spoke of experiencing medical trauma due to their abortion procedure, resulting sometimes in a mistrust of doctors or even the healthcare system as a whole. Riley shared with us, I honestly was so freaked out about medical procedures after having an abortion that I physically could not bring myself to get a diagnostic surgery to confirm that I had endometriosis. Just because I was like, man, I don't know if I want someone digging around in there again, because the first time was a little bit fucked up. We see here the recurring themes, both of people being impacted by service provision that was not supportive, but also for the need for more support post-abortion to mitigate some of these effects. And then lastly, many of our participants expressed a deep desire for community and connection with others. As they shared about the lack of support, the grief, the trauma that they might have experienced, they wanted to connect with others through peer support groups that might be accessible for people post-abortion. Many felt that only others who had also experienced an abortion would be able to understand their experiences and their feelings, expressing a desire to seek and share support with a community of those who had also accessed care. Haley shared with us, there could be support groups because I had gone a year without saying a word to anyone, even though you want to, but you don't know how to bring something up like that. Some people just need to vent about their experience. And among other things, we see the effects of stigma having an enduring impact post-abortion, and people continuing to desire connection and support, and some of our own participants even sharing that they now like to be the source of support for those in their lives who have to go through this process.
And lastly, we'll just close with some reflections from participants on the state of reproductive justice in Manitoba. So people shared concerns regarding the unevenness of care and anxieties around reproductive rights and health access given the current political climate. And they also expressed the importance of accessible abortion care for their own lives and their communities. Being able to exercise reproductive autonomy and make choices they wanted and needed for their lives was consistently described as empowering and self-affirming. So participants commonly reflected that while they personally felt they had experienced reproductive justice in Manitoba, this was not the case for everyone in the province. Many recognized their ability to access abortion care and other reproductive health care services was shaped by various factors, including race, finances, knowledge of the healthcare system, and support networks. Ivy reflected on her experience of reproductive justice in Manitoba, sharing, "I had the privilege to live in a place where I was able to make that decision. That even though I've complained about the wait times and things like that, the fact that I was able to call and relatively quickly access that for free is really important to me. And I really felt grateful for it because it's not something that everyone has. I also recognize my privilege in that I had the ability to take a day off work. I had transportation. I didn't have other children that needed childcare. I'm coming from a place of privilege, so I can't imagine what it would be like for someone who doesn't have that." Even when they were able to access care and had supportive and empowering experiences, they recognized that this was not the case for everyone. There was a broad awareness of the unevenness of abortion accessibility across the province. And the potential loss of reproductive rights was a current source of fear and anxiety for participants and really shaped and was shaped by experiences of anti-abortion protesters, misinformation, and the influence of US politics on Canadian discourse. So losing these rights was understood as encompassing not only the legal right to abortion care, but also the normalization of anti-abortion sentiment in public spaces. Renan reflected on the overturning of Roe v. Wade and other policies in the states, sharing these thoughts. "It freaked me out because if I wasn't born here, if I lived in Texas or something, my situation would be entirely different. I would have had a completely different life. I would have literally had to go through giving a new life to this world when I didn't want to." Marie notes how in the face of fear of losing rights, we must be proactive instead of reactive, sharing, "I don't think it's enough to wait for these bills to be passed, these anti-abortion bills. I think that things need to be more preventative, and I don't know exactly what that looks like, but I don't think we can be reactive. I think we have to be proactive because we understand that attacks against women's health are on the horizon. It's happening in Alberta, it's going to happen in different places." And although we note a lot of the challenges that people continue to face accessing care and throughout their experience, people also spoke passionately about the positive impact of being able to have this care and what it meant for their lives. Many described this care as life-changing, even life-saving. It allowed participants to continue their education, prioritize mental health, leave abusive relationships, and make decisions that aligned with their values and circumstances. Naomi shared, It brings me a newfound sense of joy and pride in myself too, that I made this decision for me. My whole life it's been for other people and for making other people happy, and it took something like this to put myself first for the first time in my life. And so it means standing up for myself, even if it means making these choices for me. And Quinn shared, it meant a lot to be able to do that, to have autonomy for my life trajectory and for my body as a gender nonconforming person. It was huge, for sure, to have that. So although there's a lot of work to be done in order to improve access and experience, the significance of being able to access abortion care cannot be understated.
And then, based on our analysis of these findings, we've developed 5 recommendations. So our first recommendation is to increase capacity to ensure timely intake processes and access to care. We recommend this to alleviate the stress of abortion seekers, which has been reported to be exacerbated by experiencing lengthy intake processes and wait times to abortion. Our second recommendation is for all healthcare staff and general practitioners to be trained to provide trauma-informed, culturally competent, and pro-choice care. Those who have access to abortion care will interact with the healthcare system before, during, and after their abortion. Therefore, healthcare providers should be able to support, refer, and provide information to all patients, regardless of personal opinions and the reproductive decision-making of these patients. The third recommendation from our research is to address abortion pain by ensuring access to adequate pain management, as many of our participants raised concerns about how the pain that they experienced during their medication or procedural abortion was frequently downplayed, dismissed, or inadequately treated. And this was especially true among racialized and Indigenous participants, and we flag this as especially important given health systems' legacies of minimizing racialized women's pain. Our fourth recommendation is to strengthen post-abortion follow-up supports, as few were offered much support post-abortion, and many expressed a desire for even a simple phone call to check in on their well-being. Participants also expressed interest in community-based and peer-led support groups where they could connect with others who have undergone similar experiences. And these groups could help reduce feelings of stigma, shame, or isolation, creating a space for processing, empowerment, and care. Lastly, a through line in many of our findings and recommendations is that abortion stigma continues to shape people's experience of accessing care, including getting accurate, affirming information, getting to appointments, encounters in community, but also in the health system. And this all continues to shape the way that they process their experience post-abortion and the types of isolation that people may experience and the support they may need. Therefore, we recommend that the province as a whole must work towards destigmatizing abortion. And then, lastly, an important part of doing feminist community-based research is sharing the research findings in a variety of ways to a variety of audiences. So on the screen here, we have some of the knowledge mobilization that we've engaged in so far, and this includes our community report, which we mentioned came out last week, which is an open access, comprehensive overview of the project and our findings, a presentation of our research findings at the Women's Health Clinic all-staff meeting back in October, conference presentations, including at the Canadian Sociological Association conference, as well as the Canadian Association for Social Work virtual summit. Since the beginning of the presentation, we have been active on our social media, sharing about other projects, but also educational posts about abortion and reproductive justice more broadly. And then we have a number of scholarly papers planned that we're currently working on to share our findings with academic audiences as well.
So thank you all for your time and attention today. If you have questions or any further feedback, please don't hesitate to reach out by email or via social media. And I'm sure we'll have time to chat a little bit today as well. So we invite you to follow us on social media for regular updates on research activity and as we share more about this project in different ways. And we'd like to express our gratitude to participants, to Research Manitoba as the funder for this work, the Women's Health Clinic, the Northern Reproductive Justice Network as community partners, and to the Centre for Human Rights Research for their support. And I just want to flag also that the full report is available on the Centre for Human Rights Research website. So if you want to take a look at that and have a more fulsome overview of the project and the findings, you can find it there. Well, thank you so much.
So thank you so much to Dr. Larios and to Emma Cowman for this work, and for sharing it in such a timely and really engaging way, and also for giving the students in Women's and Gender Studies 3000 such a kind of opportunity to think a little bit about research and the important work that it does. So you have some cards here on your tables. This is a good moment. We'll take a moment. There's lots of food, and we don't want to have to take it home. So maybe we can have a minute. People can get up, can get some more snacks or water or coffee if they would like it. But I also want just to take a second to thank Dr. Pauline Tennant, Angela Ciceron, Denise McInnes, and also Hannah Bellick from the Center for Human Rights Research, who've been helping work on this series. So maybe let's just take a minute. People can get up if they want to. You can jot down your questions, and then somebody from the team will come around and collect them, and then we'll have a few minutes for conversation. We're just going to bring things to sort of a close for 2:15, because I know people have classes the next bit. It turns out that this is not a group that loves writing questions down on little cards, which is okay. We all have our things. But Dr. Larios, oh, do you have a question? Whoa, then bring it on. Thank you. So glad to know when my plans work. Excellent question. What is the most shocking or interesting, or also say surprising thing that you learned, heard, or took away? It's a great question.
What always comes to mind is the persistence of stigma, especially among healthcare providers. And I say like, oh, it was shocking, but maybe it's not shocking, because actually we all see the stigma everywhere as we navigate the city in Manitoba and the different politics that exist. But I think for me it was really disheartening to hear how consistently people who are seeking care weren't feeling like they were supported even in healthcare spaces sometimes. And that's not every healthcare space by any means. Like I said, there were wonderful, positive, supportive interactions, but then we also had these really judgmental kind of moments. And I feel like for us it stuck out that, okay, yes, we can have abortion rights recognized, we can talk about access and all the ways we can facilitate access, but there's still this other layer of stigma, and what does it mean to access this care with dignity? And so that's kind of where we're kind of thinking about some of our future work, engaging with this concept of dignity in a context of highly stigmatized care. Yeah, but thank you for the question.
Yeah, I concur with what Lindsay said. I think it was also the stigma, but also the loneliness and the secrecy as well. I got to do a lot of the narrative interviews, which was amazing, but lots of people at the end told me that they had never told anyone about their abortion before. So the stigma is really persistent in even how people feel like they can talk about it and who they can talk about it to. But also some of the healing that came from participants as well, who got to share their story and talk about what that meant to them as well.
Oh, wow. Now there's
I know. As soon as I made a comment about another great question, what is the reason behind Manitoba having minimal sexual education opportunities, especially in school? And the person asks, is it funding? Is it taboos? Is it something different?
You're from Manitoba.
That's a great question, and I don't really have the answer to that one, actually. I don't have a lot of knowledge about the sexual health education space. I think we've had different politics around abortion access or talking about abortion in general, so I would imagine that some of those dynamics, some of those politics have played a role, but I couldn't say for sure. Yeah. But good question.
It is a good question, and it's actually a very good question for anybody who's interested in kind of like historical analysis, to think about taking up. Like, how did we get to where we get? Because this is where we are, but how did this come to be? So another question, could you speak to the role that the Women's Health Clinic and the Northern Reproductive Justice Network played in the project? Could you just talk a little bit more about that?
Yeah, for sure. So before we even applied for this funding, we were talking with folks, the leadership from Women's Health Clinic, and also touching base with the key organizers within the Northern Reproductive Justice Network, just about what kinds of questions they had about abortion care access. In particular, thinking about that so many of these things come up anecdotally on the front line as people are engaging in doing this care work and this support. And so as we were having these conversations, we thought it was really important to document it. And so they were involved right from the beginning of the project, even before we had the funding, in articulating the research goals. And then once we got the funding, kind of re-articulating some of those goals, helping to develop the questions that we would ask people. There were certain things that were really particular to the types of work that each community partner was doing that we thought were important to highlight and to be part of the questions we asked folks. Northern Reproductive Justice Health Network is pretty small and totally volunteer run, so not a lot of capacity to necessarily actively participate, and Women's Health Clinic is also at capacity with their work. So our role as researchers was to take their feedback in terms of what they wanted to see, what information would be helpful for them, and turn it into a project that would then provide them with information that they can then act on and actualize within the work. And so their role was they were active and responsive to consultations throughout the process. So if something came up and we're like, oh, well, like, what does this mean? What does this look like in care provision? They were there to chat with us about it. As Emma mentioned, we did site visits at Women's Health Clinic to kind of get a sense of the space, help us, again, think about the location of care. And they provided feedback on our interpretation of the findings. So when we had meetings with them to talk about, well, this is what we're seeing, does that track? Is there something that you think is missing from what we've captured so far? And so we had those discussions throughout the project. And then we're able to present the findings to them and their staff at Women's Health Clinic at least. And we will continue doing the work with them to see how this can be useful within those community spaces.
So thank you for all of these questions. We are going to just actually move to a more informal point now, but I want to both again thank Emma and Lindsay for sharing, for this work and for sharing it with us. It's crucial work, and I think we're all honored to have been here to hear more about it. I want to thank everybody from the team at CHRR, and I also want to let you know this is the first of a series of 3 events. The second one is March 11th, is a Wednesday, also at 1 o'clock, and it will be Dr. Sherry Farrell-Rosette speaking about stitching history as a scholar artist in archives and museums. And then the next event will be on Wednesday, the 1st of April, also at 1 p.m., same room, and that will be Dr. Arpita Biswas speaking on pushed out, worn down, urban displacement and the crises of social reproduction in Delhi. So, and more opportunities to learn about crucial feminist interdisciplinary scholarship happening in and around us. So please come, and thank you all very much. And we're going to save these questions and pass them on to the researchers, who will also be around for about the next 15 minutes if people want to have a little bit more coffee and stay and talk. Okay, thank you.